For several years, I've been learning a lot about the advances in orthodontics. Because of my own orthodontic treatment, I'm pleased that I look nicer, but orthodontics goes beyond cosmetics. I think that people relate to me more positively. Recently, I found out that the World Health Organization now classifies craniofacial problems as a major disease. And since early facial problems can have really debilitating effects on a youngster's future, it's wonderful that such problems can now be managed by early interception. You'll see in our video how early treatment is helping children as young as 2 or 3 years old to grow into happy, healthy youngsters, teenagers, and adults.
What is a smile? When you smile at me, it means I like you. I hope you like me. It means that I'm comfortable with you. I hope you're comfortable with me.
There is no differences between the children who are treated in Asia and in America because we treat patients individually. I think it's more or less the same in all over the world.
The teeth are part of the beauty of the face, so we attract each other with our faces.
Leaders in dentistry are saying today that orthodontics is going to be experiencing some quite exciting developments in the near future. As in medicine and dentistry, there is more and more interest in prevention and in interception.
There are 8 obvious areas of dental health. RMO is involved in all 8 of these areas, but because of the increased interest in pediatric orthodontics, we are devoting much of our time and attention towards interceptive pediatric orthodontics. We believe that this is a major direction for orthodontics in the coming years.
Orthodontics. Most people don't know much about it unless they've worn braces or their kids have. Well, I'm learning about it firsthand. You may have noticed, I've got braces, and so do a lot of other kids I know. But orthodontics today is more than just straightening teeth. It's also about improving bone relationships and faces.
Sometimes some of the things that we're treating are just purely cosmetic, aesthetic things. The patient doesn't like the looks of it, they want it fixed, so that's fine.
Obviously, if they like what they see in the mirror, and we tend to be a very visual society now, if they look in a mirror and like what they see, they will excel in whatever they do. And that's the most important thing. From the beginning of treatment to the end, there's tremendous changes in one's self-esteem. And this is true in children and adults.
The ideal age to start treatment for a child is, in general, as soon as you diagnose the problem and it is practical to treat it.
But waiting around until you're a teenager or an adult means a lot of years in school with funky teeth. And you know how kids can be. Orthodontists want us to look good, but they want us to feel good too. So some really concerned orthodontists have done lots of research and are starting to treat kids as young as 2 or 3 years old.
In the 2 to 5-year-old age group, most of the treatment I do is really directed at modifying the growth of the bones. In the later age groups, from 6 to 10 years of age, it would be bones and teeth. After 10 to 12 years of age is primarily tooth movement.
The child who has often personality adjustment problems between 6, even in kindergarten, and to 12, when a personality is being formed, if there are severe malocclusions, somebody ought to help them because they are severely handicapped on an emotional basis.
My philosophy is to try to intercept some problems before they become severe and hopefully reduce the need for extractions and surgical procedures.
I became interested in early pediatric orthodontic treatment during my training in orthodontics. At that time I was also a student of anthropology, and I became aware that the form of the face and jaws was critical in obtaining normalcy. About half of my practice is now orthodontic pediatric treatment. This allows me to finish pretty complex cases before the early teen years with stable results and a high degree of patient and parent satisfaction.
In young children, we normally try to create space in the developing dentition and also correct skeletal discrepancies before they become too severe. It's always best to correct skeletal discrepancies at a young age because that's when the patients are very cooperative and it's easier to alter the bone formation and the genetic growth of the child.
Laura was a 2-year-old child who had a problem with her chin growing too far forward. So we treated her at the age of 2 for 4 months with a chin cup. This is how she looked before treatment when she was 2. The lower front teeth were completely in front of the top teeth. This is 8 months after we stopped her chin cup. We see now that the lower front teeth are completely behind the upper front teeth. This is how she looked 20 months after we'd stopped her chin cup treatment. She's a beautiful little girl, and she's going to grow up that way now. Next, we'll show you how she looked when she was almost 18 years of age. We see that the teeth are looking great. The bite is perfect from the side. And now as we look at the front, everything is perfect as possible. This is a drawing showing how she would have grown had we done no treatment at all. Done by Rocky Mountain Data Systems. The red drawing shows how she actually turned out when she was just about 18. And the black line shows how she probably would have looked if we decided to do nothing but watch. Now we'll show you what she looks like again compared to what she would have looked like had we done nothing. And we'll grow her out to where she would have been if we decided to do no treatment when she was 2 years old. Now we'll take her back to how she actually turned out. I'm sure she's grown up being a happier young lady due to the early treatment that we did for her. I'm sure that we have positively changed her life for the better. This is one of the most gratifying areas of treatment that you can possibly do because you can truly change lives and really enjoy it at the same time.
But how do orthodontists know that the way they're fixing the kids' teeth now, when they're 3, 4, 5 years old, will still look good on them when they're an adult? I mean, we're still growing, right? Well, there's a computer-aided service to help doctors figure that out.
Use of RMOs, diagnostic simulations, are absolutely essential to proper treatment of a patient, especially those in pediatric orthodontics. If you have an individual who has a major malocclusion, you must know, number one, where the person is as far as comparison to what is normal and what is abnormal. How far off from the norm are they really? Secondly, you must know how much they're going to grow. Well, if you have that information, you're now armed, because RMO lets us know how much we have to correct now so that they will get a normal balance into the future.
The computer-aided diagnosis and treatment planning program was an extension of a manual method for growth forecasting. What the computer was designed to do was to replace all the handwork that was necessary to generate a growth forecast.
I've heard somebody refer to it as the gold standard of orthodontic diagnosis. And it's computer-aided and generated diagnosis. It is quite remarkable and quite accurate in the diagnosis.
I've used RMO's diagnostic service since the early 70s, shortly after it was started, and I've found it to be invaluable, particularly when treating young children, because you're dealing with growth over a long period of time. And I've found their long-term growth predictions to be of great value.
The reason that growth forecasting is so important to me in making decisions is because I've got to try to treat a face that doesn't exist yet. And I think that this program's done that. Personally, I wouldn't want to be in practice of orthodontics without it.
RMO has made these personalized services available since 1967 for over 30 years. We have processed close to 1 million cases, but what is so exciting is that these individualized prescription services are now available on the internet.
To understand how this interest in early treatment began, we need to know a little history.
I think it might be helpful to review some of the comments about the subject of history itself. From a negative point of view, Hegel said nobody learns anything from history. From a more positive point of view, I believe it was Santayana said that people need to know and understand history. If they do not, they will make the mistakes of history.
Orthodontics treatment was in the mind of many of the founder of modern dentistry. For instance, in 1797, John Greenwood, an American dental practitioner, treated and wrote about the importance of early care and alignment for later development of healthy adult dental functions.
In the beginning of the 20th century, Dr. Pierre Robin, a French physician, was interested in treating children, primarily in their postural and also their respiratory illnesses. And he developed an appliance called the monoblock, which was used to treat glossoptosis.
Glossoptosis is a condition in which the lower jaw and the base of the tongue are positioned backward, making it very difficult for the child to breathe and eat properly.
Dr. Robin's monoblock appliance positioned the lower jaw forward and the tongue forward so the child could eat and breathe properly. And that same concept is used today in the functional removable appliances like the Cusick orthopedic incline.
Today's appliances are similar to those, but they're smaller and lighter. They prevent conditions from getting worse, and they don't hurt.
Dr. Robin's monoblock, much like the Cusick orthopedic incline, uses occlusion and intervening guidances to correct imbalances in jaw and bone.
Braces that are attached to teeth are called fixed appliances. While they can influence bone, the forces of fixed braces are primarily used to move and position teeth.
And that's what you see in many children today. Kids with their braces on. Those are fixed appliances as opposed to the functional appliances that were developed in Europe.
Today, more doctors throughout the world are selectively using both type of appliances depending upon the needs of the patient.
Besides fixed and orthopedic appliances, there are extraoral appliances, and they're used to pull and push the bones of the face, and they are also very effective.
The latest development in this whole movement has been the development of a new bracket by Rocky Mountain called the Synergy bracket. This bracket permits treatment to be done with much less friction. Approximately 1/2 of the forces that used to be applied were taken up by the friction of the mechanism itself. So through research, there are about 6 points of lever action, which is one of the advantages of this bracket. Also, there is a lighter and a kinder appliance, a better tissue response. And finally, we have options. A selection can be made in terms of what that patient's individual needs might be.
Dr. Ricketts has been a pioneer in the development of the new orthodontic techniques and approaches to orthodontics. He has developed a tremendous understanding and shared his knowledge of growth and development and the biology and how that affects orthodontics, and also has been instrumental in the development of computerized generated diagnosis and treatment planning. His contributions in these areas have really moved us into the 21st century.
My father, Dr. William Wilson, was the ultimate student of orthodontics and orthodontic techniques. He began the development of our system where we have tried to take the best of the old and not throw that away, but also incorporate some of the new ideas and new techniques. The 3D fixed removable modular system is really a toolkit of multiple appliances to be used by the orthodontist. This orthodontic system has allowed us to link the functional or removable types of treatment techniques with the traditional fixed appliance systems. I like using the Wilson quad helix removable appliances. That's an excellent part of my toolbox. I use them all the time. The reason is that it's more efficient from a practice management point of view and from the patient's point of view. If you have to use a conventional quad helix on soldered bands, everything has to come apart, appliances have to come off, you have to solder them, lab time, and then put everything back together. It's so much easier to take a Wilson removable quad helix and just insert them in the vertical sheaths. In addition, occasionally those individuals who have thumb habits I will use my bondable habit retraining rollers and place them right on the middle of the Wilson removable quad helix appliance.
This system uses concepts of the past and of the future.
The 3D approach is built in around the snap-in, snap-out lingual tube. The center of the system is a special prefabricated band tube assembly. Oliver, Crozat, Twin Arch, Lightwire, bioprogressive treatment concepts, and any other pre-adjusted appliances can be used with the Wilson 3D fixed removable appliances.
And you can achieve over 100 movements with these snap-in and snap-out modules.
Bone remodeling is a technique that is a one-phase early treatment technique. Young bone and young fibrous tissue that connect the teeth are highly susceptible to remodeling and relocation at a young age. By understanding the remodeling of bone and how midface grows, we can literally reposition the bone to meet the needs of an excellent profile. This is the functional orthopedic incline, an ultimate functional appliance. As the lower jaw slides up the incline, it puts tension in the muscles